So, hi folks, welcome to today's session, our Sunday critical care webinars, and today is number 164. We have a very distinguished faculty today, Professor Garg, Dr. Rakesh Garg. He is one of the renowned anesthesiologists of our country, India, and critical care. He's a very senior person, and I think most of you, at least who are from India, will be knowing him. And he has contributed greatly to the field of anesthesia and critical care in our country. So he's also the editor-in-chief of Indian Journal of Anesthesia, the most reputed journal of anesthesia in our country. And he has a large number of publications, more than 350 in national and international journals. He has edited 2 books and written several chapters in various textbooks. He has also framed the Indian guidelines on CPR along with some other authors, and his area of research is very vast, and among them is airway management. So I think these are very appropriate person to speak on this, and we're really honored to have him with us and spare his time. And at the same wavelength, I would also like to mention Professor Sheila Maitra's name, another great anesthesiologist and critical care who was with us earlier, who has taken 2 sessions. You may have seen him. And to my mind, Dr. Garg and Dr. Sheila Maitra are the two great anesthesiologists and critical care specialists in our country. Of course, there are others, but I'm really honored to have you with us, sir, today. And I think the audience will really enjoy listening to you and learn a lot. Thank you very much for your time, sir.
Thank you so much, sir. Thank you so much for the kind invite. I think you are doing a great academic work in disseminating knowledge. Really hats off to you for this 164th is I think it's a huge number of critical care webinars. I'm sure that all the critical care trainees and the faculty and consultants must be really benefited from this. Thank you for your kind words also, Dr. Tapas. As you said that we'll be talking about different area today, the airway. So the airway, when we talk about, it has many synonyms with regards to the management in a critically ill patients. What we will be focusing in next around 45 minutes to 50 minutes or so about the physiological difficult airway. So when we talk about the airway management, I think apart from so many things that you do in the ICU for a patient who is critically ill, whether it is related to the airway, the breathing component, the neurological aspects, the sepsis, the other organ involvement, airway management remains one of the fundamental aspects of a good outcome of patients. We also need to understand that when we say about the critically ill patient, there are so many things patients would be requiring into a critical care setup. So why are we so concerned about the airway management and more focusing even not only the anatomical one, but the physiological aspects also? There are definitely concerns which we'll be talking in subsequent slides, but we need to understand that the body's organs do not function in solo. They are interdependent on each other, and insult to one organ is manifested to many other organs. So what is we need to maintain is the body homeostasis rather than just the organ homeostasis, and that is what is desirable. And that is the significance that though the patient is having other organ dysfunctions, but the airway management becomes equally important for the good outcome of a patient who gets critically ill. And this becomes challenging into a setup of ICU because the reasons are many. When we talk about the airway management at this particular place, there are many other concerns of like patient may be full stomach, he may be in a traumatic ICU, he may have head injuries, he may be into a sepsis with hemodynamic compromise, he may be in respiratory compromise like ARDS, he may be associated comorbidity like CKDs, liver failures, respiratory failures, he may have anatomical issues, and more or less if we talk about a critical care setup, there may be a concerns of lack of equipment or lack of trained assistant, specifically with regards to the airway expertise. And at times also in the ICU setup, at sometimes we can plan for the airway management, but many of the times it becomes urgent or semi-emergent. So this further increases the challenges that we have in managing the airway of a patient who is critically ill. The other aspects that we also need to understand for the airway management that is challenging, the airway is not static, specifically whether it is anatomical airway or physiological airway, the patient's status may not remain the same. The patients may be on an improving trend on the one hand and then suddenly succumb to some complication, or patient is just, slowly deteriorating, warranting the airway management. So this means that the plan that we have decided now may not be the same in a subsequent hour or a day. And that's why we not only need to have dynamic management, but also we need to have multiple plans. Because if we think that this patient would require airway management in subsequent hours, the patient may have more edema, patient may have more deterioration, patient may have, say, decrease in the further PF ratios without any reserves, and he may not be tolerating even 5 seconds of apnea. So this means this dynamicity or sudden occurrence of complication is an additional challenge. And that's why we just don't only need to have dynamic plans, but we also need to have modified individual plans for that patient, because each patient's requirement would be something different. And when we face any issues of difficulty in airway management, we can land up in a situation complete ventilation failure, and this is disastrous. This is disastrous with the most disastrous sequelae of a brain dead patient. And that's why we have to be very, very cautious. We also need to understand in a patient who is having any issues of the organ dysfunction. We understand that the patients who are having certain oxygen reserves, which allows the patient to be in apnea for a certain period of time, but these saturation reserves are decreased into patients who are critically ill because the organ reserves are decreased. That may be because of a cardiovascular compromise, that may be because of respiratory compromise, or that may be also because of the increased demand, because the patient may be in increased metabolic phase, in a catabolic phase, and hence the demands are more, which may not be able to sufficiently compensated by the existing reserves. And hence it becomes very, very important. And these patients can succumb to, during the airway management, succumb to apnea since they have poor response to pre-oxygenation because their lungs are not functional. They rapidly desaturate, they go into hypoxia, and hypoxia can have cardiac effects leading to arrhythmias, cardiac arrest. They can have effect on the brain leading to the other aspects also. So I think this is what we face the challenges in a critical care setup when we talk about the airway management. So having said that, we need to understand that why this all challenge, why are we so concerned about it? Now there are two particular aspects, the anatomical and the physiological. In a critically ill patients, both aspects also happen combinedly. A patient with an anatomical difficult airway can land up into ICU, which also becomes at times physiological difficult. And this is what we are looking for. And this combination becomes more of challenging in the patients that we have. So when we say anatomical difficult, we say usually that if there is any issues with the anatomy of the head and neck area, there may be a less mouth opening, there may be a short neck, patient may be obese, there may be scarring, and so on and so forth. And hence, it will lead to difficulty in the airway management. But let's more concentrate, as per the today's topic, is physiological difficult airway. Why do we say it's physiological? It means that during the airway management, the patient's physiology is already compromised, and this airway management tool will lead to further derangement, and that can succumb to the further deterioration of the organ functions. And this physiological derangement may be pre-existing to varied severity depending upon the patients for which the patient is admitted into the ICU. It may be that the patient is having raised ICP, neurophysiologic derangement. He may be having a cardiovascular derangement. He may be having a respiratory derangement. He may be have a hepatic, renal, gut, all these arrangements. Or the patient may be having sepsis with multi-organ involvement. So this means these all we will be discussing more in detail. These all factors are not isolated organ dysfunction. But when we try to manage these patients for airway, they may have impact on the airway management, or airway management can lead to certain deterioration in these functions, and the patient could succumb to organ injuries. And obviously, there could be combination of both, as I mentioned. Now, out of these all physiological difficult airways that I just mentioned, three things are most important, and which is quite commonly also seen in patients who are critically ill: hypoxia, hypotension, and metabolic acidosis. Now, these are the main crux that we will see in majority of our patients who are admitted to ICU in a critically ill phase. And these are so sad as physiological difficult airway in case the patients with hypoxia, hypotension, or acidosis require the airway management. Though there are many, as I just mentioned, and we'll be discussing them also. Now, let's come to the first aspect, hypoxemia. Why or what are the concerns for difficult airway in these patients? Now, when we talk about critical ill patients, because of the organ involvement, they have reduced functional residual capacity, and hence they have less reserves. They also have ventilation perfusion mismatch. There may be increased amount of shunt, and all those things which will be acutely worsened when we try to do the give some drugs for the induction of anesthesia for the airway management purpose. The FRC will further decrease, VQ mismatch and shunt will further increase. And hence, if they increase, then there will be more respiratory compromise and patient will get more hypoxemic, which is already patient has. And hypoxia, we know that the other organs will be equally affected. And hence, this is one of the major concerns for which the airway management is required in the critical ill patients. And we have to be very, very cautious, needs to have certain plan, pre-plan, so that we are able to manage this expected insult or occurrence of the hypoxemia during airway management. The common conditions that we would see will be responsible for hypoxemia or occurring of hypoxia, maybe like pneumonia, maybe VAT, maybe atelectasis, ARDS, pulmonary edema, increased secretions, mucus plug because of the septic and increased secretions. Patient may also be comorbid like obesity, or their GCS is poor. Again, those patients will have poor respiratory reserves because they are bed-bound, that atelectasis already happened. And these factors of edema, more secretions, plugging, this will become more worsened. The hypoxemia will become more worsened once we try to make the patient asleep with the effect of certain drugs for the purpose of airway management. So what needs to be done? What should be the options with us? That we need to have a balance between the existing physiological changes. On one side, we are saying that the patient has decreased oxygen delivery, and on the other side, we have increased oxygen consumption also. So this will lead to obviously the further hypoxemia. And if this patient has poor reserves, more utility, more utilization, so any amount of apnea will lead to the sudden collapse of these patients, and that becomes very, very important. So when we take care of it, what needs to be done? We have to manage the airway, no doubt about it, but what we should do? So we know that patient have decreased reserve, patient requirement is increased. What we need to do is, we need to have certain strategy that this hypoxemia is not further exacerbated during the airway management, because desaturation is the biggest risk of cardiovascular compromise, even to the extent of cardiopulmonary arrest. And the patient may have FRCs because of the other aspects. So what we need to do is, all the patients during the airway management should be appropriately pre-oxygenated. And during the airway management, the oxygen supplementation must continue. And nowadays, we believe that this needs to be done at higher flows. Earlier, we used to say 15 liters, but now we have higher flows in the form of high flow nasal cannulas. We can deliver up to 70 liters. So these type of oxygenation strategies will probably deliver some amount of oxygen in a compromised patient, so that during the airway management, the period of apnea, the period of hypoventilation will be further decreased, because some oxygen is going inside the body through these mechanisms. Some reserve is increasing by this mechanism, and then the patients probably would be tolerating the airway management strategy. Also, we also know that the patient who is in upright position have less decrease in the FRCs, they have more reserves. And when we do pre-oxygenation, they will have more reserves. So these patients may be managed in a upright position or at least head-up position of 20-30 degree. Delayed sequence intubation is one of the options in patients who cannot tolerate pre-oxygenation with an IPPV or HFNO. Now, this is what we need to summarize. When we say which patient needs oxygenation during airway management in the ICU setup, so no confusion. All patients during the airway management must receive 100% oxygen at high flows while the airway is managed. And yes, we understand that giving 100% oxygen for long duration is not warranted as per the many guidelines, but airway management will take a couple of seconds to minutes, and then we can wean off the oxygen, or you can say titrate of the oxygen as per the patient's requirement. But during airway management, oxygen supplementation must be ensured to these patients, because oxygenation, but whatever technique at high flows, will have some transflow of oxygen across the alveolar capillary membrane, and they will increase the reserves of these patients. And this has been very well studied that the incidence of severe hypoxemia is decreased once we start giving them pre-oxygenation and continue oxygen using high flow nasal cannula in these patients. The chances of the hypoxemia is much decreased. We also need to understand that certain patients would require, in addition, some NIV support because they will have a lot of atelectasis, they will have collapse of the alveoli. So probably before we go for the mechanical ventilation after airway, I think somewhere in addition to the oxygen therapy, some patient may require some PEEP and pressure support in the form of non-invasive ventilation so that they can better tolerate the airway management tools. Now, with the availability of the high-flow nasal cannulas, the high-flow nasal oxygenation technique has become more popular. It just not only generates some amount of PEEP and pressure support, but it also gives a higher flow, and the passive insufflation, even in the apneic oxygenation, becomes more easier, and these patients tolerate the period of apnea shade better than without the supplementation of oxygenation. So this becomes an important tool that is warranted in patients with those physiological difficult airway, even for anatomical difficult airway that needs to be managed. Simultaneously, the airway techniques should be done because these patients cannot tolerate apnea for a longer durations because of the underlying organ dysfunctions. We should be well versed with the organ, with the armamentarium, which has a better success rate, and the use of video laryngoscopy probably is one of the good options. We can also use certain supraglottic airway devices, which can be a rescue measure in the event that if you are not able to ventilate these patients using a face mask, we can always use as a rescue measure of the various supraglottic airway devices available. And then either an expert can intubate it, or we can also intubate it through these devices so that these patients do not succumb to hypoxemia during the airway management. CPAP therapy, as mentioned, is also a life-saving strategies in these patients, especially patients like ARDS patients who require mechanical ventilation and needs to be put with tracheal tube. You can start on CPAP therapy, and that will take care of the increasing reserves. And probably we have the mask devices, which has a diaphragm through which even we can ventilate these patients. And that's the reason if you see the guidelines for the airway management in the critically ill patients, they do talk of oxygenation throughout the process. So what I mean to emphasize here is, yes, hypoxemia is a major risk, but we have tools, strategies available that needs to be continued for various strategies of oxygen delivery to these patients throughout the airway management. And then subsequently, once the airway is secured, patient is put on mechanical ventilation, probably we can titrate or wean off the oxygen as per the requirement. So to summarize what I have said about hypoxemia, what needs to be done? One is pre-oxygenation using a high flow nasal cannula. We can use non-invasive positive pressure ventilation to these patients in case required. We can also use the pharmacological measures like inhaled pulmonary vasodilators like nitric oxide in certain group of selected population, which probably reduces the ventilation perfusion mismatch, and the oxygenation can be better optimized. It's just not the pre-oxygenation, but during the apnea period, we should continue oxygenation through the same routes of high flow nasal cannula or even a static nasal cannula high flows. But yes, it is preferred to have high flow nasal cannula with high flows because they have better effect. They can also have the effect of some ventilatory exchange, taking out the carbon dioxide, and chances of hypercarbia is further decreased. Certain patients will have refractory hypoxemia. In these patients, be very careful not to give them drugs, not to make them asleep, or not to make them apneic. They can be managed in a spontaneously breathing with oxygen supplementation, so you should be careful. Nowadays, we also need to incorporate certain other tools to prevent this hypoxemia or treat this hypoxemia in these patients. Like, for example, the point of care ultrasound. Now, they are happening because when we say we need to ventilate, there could be some pneumothorax, there could be some pulmonary edema because of fluid overload, there may be a sogging lung, an ARDS patient. So use of the point of care ultrasound is one of the bedside important tool that can be used in these patients who are having physiological difficult airway for airway management. Yes, pulmonary vasodilators, as I mentioned, can also be used for managing by decreasing the VQ mismatch. And even right ventricular afterload is one of the issues in these patients that can also be taken care of. So from the hypoxemia point of view, from physiological difficult airway, we have to use technology, tools, techniques, and thoughts, that is guidelines, in an appropriate way. We just not have to prevent them resaturation or desaturation, but what we need to target is more importantly, we need to maintain oxygenation. It is not stop-gap approach or stop-give oxygen approach, but a continuous oxygen insufflation needs to be continued so that we can attempt to maintain oxygenation in these patients. Now, coming to the second aspect of physiological difficult airway is hypotension. Patient who requires mechanical ventilation, they may be in sepsis, they may be distributive or hypovolemic shock states, and that may have associated decreased venous return. Moment we give certain drugs to these patients, because they are compensatory to maintain the pressures. So moment we try to decrease those compensatory mechanism by giving any drugs, even a small quantum of drug, maybe say 1 milligram of midazolam or 20 micrograms or 2 to 3 ml of propofol, these patients will have decreased return, depressant action, and further precipitating hypotension. So that's why we have to be very cautious. And not only during this management, but the moment the patient is managed with the airway and put on mechanical ventilation, because of the increased intrathoracic pressure, these patients will also succumb to further hypotension. And this is what the physiological derangement happens in these patients. And that becomes a major issue because hypoperfusion will lead to further organ damage. The patients who are admitted in ICUs may be hypovolemic because of many reasons. And when we use the drugs for tracheal intubation, maybe the barbiturates, propofol, maybe the benzodiazepines, the opiates, they usually have vasodilating and myocardial effect. And moreover, the compensatory mechanism, the adrenergic stimulus, will also be obtained, which was maintaining the pressures. And this whole scenario will lead to precipitation of the hemodynamic decompensation in these patients, compromising the perfusion of all the vital organs. And there have been many studies, and they have found that almost half of these patients will have cardiovascular instability when we are going to manage these airways in a patient who is critically ill. And the use of drugs becomes important. Now, when we say the anesthetic drugs, yes, we need to think of option awake versus asleep. And when we say asleep, there are various drugs that has been available, like including thiopentone, etomidate, ketamine. These are the commonly used drugs for these patients, and various combinations has been used. We understand that the drugs like propofol causes a lot of hemodynamic instability, and in this patient, when they have compared, they found that there is no difference in the mean maximum score in first 3 days, no difference in intubating conditions, and more patients with adrenal insufficiency with etomidate. And hence, the use of these drugs may be used for management in patients with critical ill, and the resurgence of ketamine is coming up because of its some beneficial effect on these patients. But we have to have a balanced approach considering both the aspects, because etomidate will have some adrenal insufficiency as compared to the other drugs, and hence they may not be the best drug for this, but yeah, these are one of the available options that can be used carefully. Even in the INTUBE study, it was mentioned that the propofol was the only factor independently associated with cardiovascular instability, because it causes a lot of hemodynamic changes like vasodilatation, myocardial depression, and hence the cardiovascular instability is much higher when you start using drug. So probably in the armamentarium, maybe the ketamine and etomidate are the options that may be available. Ketamine probably have some beneficial effect in the initial phases of sepsis before the sympathetic compensation is complete. So what we have just discussed, a patient requiring airway management, having a physiological issues of hypotension, the risk factors needs to be assessed for these patients. We also need to understand that the hypotension, the induced by our airway management drug techniques will have severe impact, leading to increased morbidity, mortality, length of stay, and organ injuries. And hence, we should be looking for these patients who have a high risk. The fluid responsive and fluid tolerant patients should be given fluid in these patients. And in case if they are not responsive, we can also think of starting them on vasopressor infusion even before we start airway management, so that the hypotension that will be precipitated by the process of intubation, including drugs, IPPV, and the suppression of the sympathetic stimulation, the hypotension that needs to be managed with fluid in addition to the vasopressor drugs before we start attempting. So to summarize, for the second aspect of physiological airway, we need to think of volume administration in these patients as per the patient's requirement. Think of vasopressor and inotrox support appropriately. Before you start the airway management, the drug should be ready, connected to the patient, and they may be started moment the patient shows signs of hypotension. We should be cautious in using our induction agent. Propofol is associated with good amount of hemodynamic instability, though we do not have superiority of ketamine over etomidate or vice versa, but they can be chosen based on the patient-to-patient choice. Try to use the point-of-care ultrasound to look for the reversible causes in these patients and try to manage it so that the injuries because of hypotension during airway management do not happen in these patients. Now, specifically coming the drugs that we have discussed, that what could be the possible ways of modes of induction. So usually what we do is the rapid sequence induction and intubation, delayed sequence intubation, awake intubation, or double setup approach. So these are the 4 techniques for inducing these patients for airway management. Yes, if any route, go for the awake intubation. That is the best modalities, because we are not looking for the drugs that will have side effects on these patients. And in this, we don't use the induction agents or the muscle relaxant. Usually we put some blocks, topicalize the patients, and then go away with airway management. For rapid sequence induction and intubations, we use rapid acting agents. In these patients, usually it is ketamine or etomidate based in critically ill, I just mentioned. We can use succinylcholine or diclofenac in these patients, and then we can go ahead and put for the airway management. In delayed sequence intubation, the pre-oxygenation is done after judicious use of sedation in delirious patients, so that you can pick up those patients. They may become more cooperative, and then you can go ahead. In double setup approach, 2 approaches are prepared simultaneously in anticipated failed intubation, for example, RSI and surgical airway. And this becomes very, very important, as we have mentioned in the previous guidelines also, that in case if the first attempt fails, you must be ready with the second attempt immediately, because this patient does not have reserve. They will not give you time. Hence, the preparation and planning should be done in advance of these patients. Coming to the next aspect, the right ventricular dysfunction. This is another important aspect of physiological difficult airway in patients with coming for the airway management. Now, whenever these patients who are critically ill, before we go for airway management, we should screen them up for the risk of decompensation moment we start them on mechanical ventilation. If they are, then we should be looking for the fluid response in these patients, the need of vasopressors in these patients, and they should be given appropriately. The fluid intolerant patient should have RV afterload reduced with pulmonary vasodilators, which is required depending upon their underlying etiology. Even these patients may be put on ECMO for better oxygenation in case if they goes into failure. We should avoid using hypercapnia. They should be appropriately controlled, but simultaneously we should also be cautious that the high intrathoracic pressure or hyperventilation should not be given to these patients. We can increase the mean arterial pressures to maintain the coronary perfusion pressures in these patients. And in patients with these patients who have any amount of RV dysfunction, the chronic pulmonary arterial hypertension, a higher MAP should be targeted to keep the mean MAP to more than mean pulmonary artery pressure in these patients. And try to keep the mean airway pressures lower. The intrathoracic pressure needs to be kept low. So this is what we need to circumvent the physiological difficult airway because of right ventricular dysfunction. The other important aspect in critically ill patient is with regards to the severe metabolic acidosis, which happens because of the underlying various issues. The respiratory acidosis may be improved with some oxygen support or NIV support, but the metabolic acidosis is an important issue that also needs to be taken care of. And the hemodynamic instability induced by induction agents further precipitates the acidosis in these patients. So they are one results in the other one, and hence we have to be very cautious in airway management because they can succumb to multi-organ involvement and the risk of increased morbidity and mortality are higher. These will decompensate very fast due to volume depletion and inadequate alveolar ventilation after intubation. So these patients should be very cautiously. They may not be given intra. You need to have an awake airway management in these patients who are having severe metabolic acidosis, and then you can accordingly subsequently manage their ventilative strategies. So to summarize what I have said about the metabolic acidosis, we can delay intubation for these patients and try treating the underlying etiology and the acidosis. We can keep them on a non-invasive positive pressure ventilation. If required, if it's necessary, we can think of the awake intubation and then spontaneous ventilation. But remember, apneic oxygenations and the peri-intubation, the bicarbonate boluses or the infusion should be considered in these patients, though they are debatable. But yes, soda bicarb can be given to these patients required if they are having severe metabolic acidosis. The other component of physiological difficult airways, neurological injured patients, is a specific subset of population which is big issues for the airway management. In these patients, we should be keeping eucapnia. We should be keeping them hemodynamically neutral reduction agents. Patients should be positioned 30-degree upright so that they have better perfusion, but better drainage also. And we should limit the PEEP so that the ICP is not increased and cerebral venous drainage is better. There are many other physiological reasons for difficult airways, which could be like cardiac tamponade, valvular heart diseases, hypermetabolic state. These also needs to be considered in sepsis patient. So there is a whole array of physiological difficult airways during the airway management that must be considered. And many of these factors can be optimized to a certain extent. We cannot normalize them. And hence we should be able to find out these causes and treat them accordingly. We also need to be a little concerned about the impact. So I have just mentioned about the endpoint of happening, like say hypoxemia or hypovolemia or RV dysfunction. But if you see the other organ dysfunctions, they also have an impact. For example, the hepatic derangement, it also leads to physiological difficult airway because these patients may have hepatic NCAF, raise ICP. Airway management will lead to increase ICP further. They may have coagulopathy or thrombocytopenia. So airway management, especially the nasal intubation, may lead to a lot of bleeding in these patients. Similarly, the renal derangement, CKD patients, they already have metabolic acidosis. They can have hyperkalemia. So you need to avoid succinylcholine. You can use rocuronium. These patients will have fluid deficit stage, so you can start them on vasopressors. Severe metabolic acidosis, you can start them on sodium bicarb infusion before you attempt for tracheal intubations. Similarly, for the gut dysfunctions, palatic ileus, pseudo-obstruction, raise intra-abdominal pressures. All this can lead to increased risk of regurgitation and aspiration during airway management, which has, again, increased morbidities and mortalities. Also, the fluid shifts can lead to hypotension during induction if you're using drug-based airway management in these patients. Sepsis, all those features which I've mentioned earlier can be seen in sepsis, distributic shock, lactic acidosis, coagulopathy. So we should be cautiously, resuscitating them as the time permits. Try to use vasopressors, try to have monitoring of hemodynamics, and you can use etomidate and ketamine, as I mentioned earlier. So what I have mentioned in last few slides with regards to the management of physiological difficult airway, what are we looking for is the device technology and techniques. We also need to look for expertise, communication, and team approach, which is very, very essential. We have to use all those gadgets available. We have talked about various modalities. We have talked about various drugs, but simultaneously, we need to have a teamwork which can execute the skills and plans that we have desirable. We may fail in one. That's why we have to have rescue plans for airway management in these patient groups also. We need to assess simultaneously. A patient with physiological difficult airway can have anatomical difficulty also. So do assess these patients, the upper airway and lower airway for anatomical difficulty, so that you can plan airway management so that both can further lead to more difficulty, more morbidity, more mortality, and hence assessment becomes very, very important for upper as well as lower way, even in patients with physiological difficult airway. The patient cooperation is a big issue in these patients because hypoxic patients, sepsis patients, they become restless. And hence you should be looking for any difficulties and preparing a plan accordingly, preparing a call for help timely so that these patients can be managed. Now, next 2-3 slides, I want to just emphasize on the dynamicity of the airway management. So even the airway management, there are certain physiological change that happens. Static factors, we understand. The anatomical factors, we understand. But the dynamic factors are equally important. The dynamic factors, as I mentioned, at the moment you intubate, the respiratory mechanics changes, the pressure flow impact changes. The patients may have a lot of changes in the physiology as such. They will have hypotension, may have hypoxemia. They may have a retention of carbon dioxide or washout of carbon. So there'll be a lot of physiological changes in these patients when we start managing them. And these dynamicity of the factors, of the anatomical factors, again, is dynamic because of various physiological change. And hence, we should be a little cautious about them. Can we predict them? Do we have some predictive tool for these difficult airways? Yes, we can. There have been 2 scoring systems that has become popular. One is the CRASH. So I have already mentioned the details. So this is mnemonic is just for remembrance. CRASH, consumption increase, that is increased metabolic demand, right ventricular failure, metabolic acidosis, hypoxemia, that is desaturation, hypotension. Similarly, the Makocha score has been found to be a good predictor of the various morbidity and mortalities. And these are the points that has been covered: the Mallampati, the obstructive sleep apneas, reduced cervical spine instability, mouth opening coma, SpO2 and non-anesthesiologist. So these are the predictors of the difficult airways in critical ill patients. So what we need to is we can use the combination of scores to understand whether they have some difficulty in airways, and we can call for help at the early so that they can be managed without having any issues for the decompensation of the compensated organs earlier. We also need to have the understanding of the various imaging modalities before we start for airway management, or before we think that this patient may require the airway management further. Start to think of the available imaging modalities and try to look for the airway difficulty in these patients. Nowadays, people have started using virtual endoscopies images also, because CT is sometimes done for these patients of head and neck area. Same CT films can be used for virtual endoscopy and reconstructive images to look for any difficulty in these patients. The ultrasonography has become the bedside tool now. I mentioned earlier also that not only the airway assessment, but also the physiological treatment can be picked up through the bedside ultrasonography. They have various applications in the airway management, from the airway size, prediction of difficult laryngoscopy, the device placement depth, the procedures. In case if we fail, sometimes we have to do the surgical airway in these patients so they can help in those aspects. And obviously, you can look for the reversible causes and complication of the airway management. The understanding of sonoanatomy becomes very important because, as I mentioned, the airway management is quite dynamic. If you keep it, you can look for the various structures of the upper airway. The tracheal cartilage, you can look for the muscles, you can look for the cricoid cartilage, you can look for the vocal cords in these patients. You can also look for the cricothyroid membrane, which is an important landmark of a surgical airway in case you are not able to secure the airway properly. You can look for the tracheal rings easily in these patients in case if a patient requires percutaneous tracheostomy. You can easily look for the other structures, the thyroid membrane and the other aspect that can be easily visualized in these patients. You can also look for the floor of mouth for any masses, lesions, focus of lesions or infective focuses can also be looked for in these patients. You can also confirm the correct placement by looking for the esophagus in these patients. And in case of esophageal intubation, that will be poorly tolerated by these patients. So you can easily look for that whether patient has tube into the right place or into the esophagus. We can also predict the right size of the endotracheal tube by using the ultrasonography and the correct placement. One, I said esophagus. Secondly, the double ring shadow, double track sign can also be seen in the trachea. As I mentioned, virtual endoscopy, many of the critically ill patients probably may have the CT scan. Same film we can use for reconstruction, and you can easily peep inside using these virtual endoscopic pictures of reconstructive images to look for the configuration of the airways in these difficult airways. And you can easily see if there is some obstruction, some lesion inside the airway so that you already know it and can manage these patients more safely accordingly. Now, having said that, we have understood that these are the concerns. We understood that these are the predictors. We can use these tools. How about managing these patients now? We have understood that the physiology needs to be stabilized, and simultaneously, accordingly, we need to pick the correct approach for airway management in these physiological difficult airways. The techniques, as we have already discussed, awake versus sedation. Position, we already said that patient should be head up in majority of position to increase the reserves. The position of intubator, depending upon the position of patient, can be on the head and on the sides. Routes, nasal or oral, depending upon situation. Usually we prefer oral routes for majority of our patients. And then we can make plan, arrange the things, call for help early, and coordinate. We do have guidelines where we have stepwise approach for airway management in these patients, starting from using of the pre-oxygenation that we have already mentioned, and the oxygenation needs to be supplemented. If we have, we can use the video laryngoscope, the preferred one for airway management. If fails, as a rescue, we can go ahead with supraglottic airway devices and then think of, we can intubate through a supraglottic device, or we can have surgical airway in the form of percutaneous tracheostomy in these patients for further airway management, because supraglottic airway device may not be the appropriate tool for ventilatory strategies in a patient who is having the respiratory dysfunction, the lungs dysfunction. We also need to remember that the surgical access in the form of surgical airway, including the surgical tracheotomy kit, should be available in these patients in case if we are not able to ventilate the patient during the process of airway management. To summarize once again, we need to understand the technique, awake versus inhalation with spontaneous, or awake versus inhalation with use of neuromuscular blocking agents. As I mentioned in the beginning, depending upon the difficulties, you can think of awake or under induction. And the route nasal versus oral versus tracheostomy. So it all depends upon the initial assessment, or during the assessment, if you are a failure, you can go for a surgical access. Awake fiber optic intubation remains one of the gold standard in case if you predict a difficult airway, and then you can choose the airways as I just mentioned. You need to understand your equipment well. You should be well practiced for these patients at how you to use equipments, and then gradually you need to follow the standard stepwise approach for fiber optic intubation in these patients. Start with nasal endoscopy, the pharyngoscopy, the laryngoscopy, tracheostomy, because in critically ill patients, these patients can have lesions at any of these sites, and hence, not only to examine them properly, You have to visualize them and have to avoid trauma, because these patients may be in sepsis and coagulopathy, and hence you should be careful while you are managing these patients. The limitations of flexible fibroscopy is definitely an issue, because these patients may be uncooperative, they cough a lot, they can have secretions, they can have airway trauma. So you have to be a little cautious if they don't cooperate. If they have trauma, you should be ready for the next plan of the airway management. Asleep, definitely they are better. The patient is better cooperated, controlled situation, lesser airway, but thus it can compromise the airway. And we have discussed earlier, the chances of hypoxemia is much higher in these patients. Also, the drug-induced hypotension and other aspects is to be there. So what we need to is we need to have a balanced approach. We need to have an individualized approach based on the patient assessment and try to look for. Be careful with the selection of drugs with the pre-medication. They should be used minimally as per the patient's requirement. You should be ready for their side effect. The use of opiates, especially the fentanyl in low doses, are acceptable. The use of benzodiazepines are not a good option, because even a small dose can lead to the airway compromise. Propofol, as I mentioned, is not again a good option. Nowadays, there is some role of dexmedetomidine that can be used in these patients. Though the Western literature says a higher dose, but Indian patients require a little lower dose. 0.5 to 1 mics per kg is sufficient for the airway management, provides not only good sedation, but analgesia also. When you're managing these patients with having physiological issues, we need to handle the airway minimally, because each will have a lot of response, a lot of trauma. So keep your ancillary equipments ready where you're managing the airway management. These are the equipments that are required for airway management using fiber optic scopy. You can use these type of masks to ventilate while you are providing NIV or pressure support PEEP to these patients, and you can ventilate through the diaphragm of these devices so that these patients do not have episodes of hypoxemia. This is how you prepare the trolley for the airway management using this special mask, the endoscopic mask, through which you can ventilate easily while patients is being ventilated using this NIVs. So this is the diaphragm you can see, which you can use, and this is the airway that keeps the airway patent. And this is how they can be intubated through the diaphragm while the patient is receiving positive pressure ventilation. We can also use the hybrid techniques wherein, as I mentioned, the supraglottic airway devices can be used for ventilating it. And through these devices, we can go ahead and intubate these patients using fiber optic scopes. So these are all the important modalities. We need to be well equipped in managing these patients with physiological difficult airway, so that they are not succumbing to the additional complications and they are not decompensating with organ insult. The other issues in these patients would be the secretions that come up, because they maybe have respiratory infection. They put a lot of secretions. Keep those wide bore cannulas ready, because sometimes thick purulent secretions cannot be taken care through the fiber optic scopes or through normal catheters. And hence these Yonker cannulas are good for looking for the secretions. And sometimes even the bleed also, they can be sucked easily by these cannula rather than catheters. Now, we also need to understand ergonomics in the critically ill patients, because a lot of things will be done during the airway management. Somebody will be on the head end looking for the airway, somebody will be giving drugs, somebody will be looking after the monitors. So this is how you need to arrange yourself appropriately in an ergonomical way. And this is one of the acceptable standing position of the various team members during the airway management in a patient who is critically ill. This is again essential so that a team approach can be provided to these patients during the airway management. And hence, we should be taking care of these aspects also. Be ready with your backup plan in case everything fails. Patient gets hypoxemic, patient gets desaturation. This is one of the emergency technique, which is called surgical cricothyrotomy. You just require three things. You require an endotracheal tube, size 6. You require a scalpel blade, and you require a gum elastic bougie. And that's why this is called stab, twist, bougie tube technique, wherein through the cricothyroid membrane, which we have identified, maybe we can use ultrasonography to identify it. And then we can use this technique to intubate faster, and can be done in a couple of seconds itself. And you don't require some special equipments, and all those three equipments are usually available in any of the airway cart. Having said that, you have managed your airway nicely, but these patients, because of the effects that we have discussed in the last few minutes, the patient needs to be stabilized because of the effect or the impact of drugs and the interventions that we have done. You maintain the ventilation oxygenation, the hemodynamic stability should be taken care of, the acid-base balance needs to be taken care of. Patient may require sedation and paralysis, and the other organ care also needs to be continued in these patients. Having said that, when we say physiological difficult airway, yes, we have taken care of it, but we need to extubate them also subsequently. It's not over. Extubation is again important. So let's just think of a little bit of it. So when we saw about the extubation in these patients who are critically ill, we need to look for what insult has happened during the process or during the weaning of the patient. And that's why these guidelines are again important, where we talk about the various aspects. These patients can have airway collapse, they can have recovery, delayed recovery, they can have issues if they are a surgical ICU, they can have, because surgical insult leading to the compromise of airway in these patients. And hence we should be looking for these aspects also during the extubation. When we don't have done feeding, during extubation, we should be cautious, looking for these causes. And now the extubation is an elective process, so we should be optimizing these aspects before we extubate these patients. So to summarize, we need to understand that the patients who are critically ill, they have various physiological derangement, and they can attribute to the physiological difficult airway, which is related to various organ systems. And hence, the right practitioners with the right training is essential for this, who can understand and plan with the right equipments and with the right preparation, which is individualized as per the need of the patients. A right assistance in the form of call for help, a trained help, and the right location is essential for an uneventful airway management in a patient with physiological difficult airway. And probably this is going to improve further because we have discussed multiple aspects of different organ systems with different inputs. So probably the future lies again into the artificial intelligence, because in these patients who are critically ill, there are multiple inputs: respiratory, cardiovascular, sepsis, metabolic, anatomical, physiological. It becomes a little difficult to collate into one and take some decision. And probably it appears that, as I mentioned in this also for airway management, that the artificial intelligence will try to gather data from the multiple inputs and will give some useful individualized decision chart for the management of these patients. It cannot be 1 + 1 = 3. It will be based on our clinical evaluation traditional scores with fed into the artificial intelligence, and that will give us a decision-making model. Probably this is the future. We have yet to see. I'm sure that this will help us to make decisions which will decrease the morbidity and mortality, increase the success rate in these patients, and it's not only predictive, but also decision-making artificial intelligence. So to summarize about the physiological difficult airway, we need to understand our patient. We need to look for the risk and risk predictions, and then try to optimize for the physiological issues, whether it's hemodynamic, whether it's hypoxemic, whether it's metabolic acidosis, neurophysiology, or other organ dysfunction. And considering all those aspects, if we can optimize to a certain extent, yes, but then certain things cannot be optimized, because I say pre-existing hypoxemia is the indication for airway management. We need to go ahead and try to take some mitigating strategies so that these patients do not get further insulted. And then post-procedure, these patient stabilization needs to be continued so that they have a better outcome. So thank you so much, and greetings from my side to each one of you. Thank you so much. Any queries, questions, you are most welcome.
Well, thank you, Professor Garg, sir. Very nice, elaborate, detailed, and wonderful lecture, starting from the basics and going into the world of AI, where we are all looking towards. So, audience, please type your questions if you have. Meanwhile, sir, two very important takeaway points I will highlight from your talk. One is that fluid should not be rushed in if there is hypotension or suspected hypotension. It's very clearly shown it will worsen the situation if the patient is not tolerant of fluids. Right. That is very important. Give vasopressors. And
Absolutely.
it was shown in the INTUBE study, the commonest peri-intubation problem was hypotension and not hypoxemia. So that's very
Absolutely.
important. Don't push in fluids, my dear audience. Just assess if you can, if you have the time. Otherwise, start the vasopressors. Or if you think the patient will tolerate or will be responsive to fluids, then only push fluids. Second point is AR, that is for sepsis or hypotension, which is very common. The other thing is about ARDS. So please use NIV, pressure support and PEEP for pre-oxygenation. That is again very important. Ferrari 2 trial shows this very clearly. It is very helpful. Otherwise, it's very difficult to oxygenate these patients. So those are, sir had shown all these 2 points, and I'm just highlighting for the audience. This is not a common practice, I know, amongst the youngsters and in the smaller ICUs. Maybe the bigger centers like AIIMS and other centers do this, but in smaller centers, this is not the practice. And while we wait for the questions, sir, I'll just throw up a few questions for the audience. So, sir, one is about the sepsis and ARDS, the two common situations we face in the ICU. So just, as a practical guide to all the younger people, one for sepsis with hypotension, acidosis, organ failure, we're intubating, and one severe ARDS, two patients. What palliative agent, sedation, and what will you do at the bedside to just hands-on intubation?
Absolutely. I think both the scenarios are quite common in ICU setup. ARDS patient who is not responding to the conventional conservative measures which require intubation and then subsequent management, prone positioning, and other things. So these patients probably will be put on, nowadays people put on HFNO, the NIV remains the usual strategies. So as a part of oxygenation, you continue with the NIV in these patients with whatever the requirement of pressure support and PEEP for maintaining oxygenation throughout the procedure. Now, when you are managing the airway, there are two options for you. If the patient is not tolerating any amount of NIV in these patients, you can use an endoscopic mask and intubate through it. If the patients can tolerate off NIV for some time, use HFNO for continuing oxygenation, and then you can go ahead and do it. Now, you need to take a decision between asleep versus awake. Probably awake remains the better option in these patients. Topicalize nicely the airway and go away with the awake intubation without compromising it. In case if you think the patient does not have an anatomical difficult airway, you can start thinking of using the shorter acting opiates like fentanyl. And I'm happy that remifentanil has been introduced into India now. It will make more life simpler. It's a very shortest acting opiate, and you can add it on with ketamine, with etomidate for managing the airway in these patients in case if a sleep is required. Otherwise, awake would be the better option. The second scenario that, sir, you mentioned was about the patient with sepsis, with metabolic derangements in these patients. These patients obviously will be very, very hypovolemic, and be very cautious. You cannot rush them with fluids because they will have leaky capillaries. They can go into pulmonary edema. They can go into other type of complications. Keep your vasopressors ready and connected to the patients. Give certain fluid to these patients. Look for the response. If required, you can start on vasopressors for these patients. Now, once you have done it, your option is awake versus asleep. If the patient is cooperative, oxygenation needs to be continued, do awake intubation. If you think the patient is non-cooperative, in these patients, you have to sedate them. Again, the use of drugs like ketamine or etomidate would be the option in these patients, and you can go ahead for managing these patients. And then subsequently, you can use neuromuscular if required. In case if there is a high risk of regurgitation and aspiration, if patient has recently the food, then do think of rapid sequence induction intubation in these patients. Succinylcholine remains one of the drug of choice, but in patients who are hyperkalemic, succinylcholine may be not the right drug. In those, you can use rocuronium. And now, since we have Sugamadex available, in case of difficult airway, they can fastly reverse it. So we are a little more comfortable because rocuronium is a longer acting agent and can be used for the purpose of rapid sequence induction intubation. So this is how you need to manage it. And also, when we talk about the sepsis with the metabolic acidosis and other derangements, Yes, slowly there needs to be fluid resuscitation where the acidotic components is taken care of. But sometimes when the pH is say less than 7.2, we can even start the infusion of soda bicarb for these patients to tide over that phase and then try to reverse the reversible causes, which is causing metabolic acidosis, including fluid resuscitation as per the patient's requirement.
Thank you, sir. Wonderful, sir. So just, sir, a couple of points more about ketamine. So, sir, what about the role of ketamine in raised ICT? I mean, there's some controversy. Is it okay to go ahead with it?
Yeah, absolutely. I think ketamine has been found to have issues with the increase in the intracranial pressures because of the increased intracranial intraocular pressures. That controversy is still there. There is nothing called yes or no. But then we have other options like etomidate, which can be used in these patients. So if a patient is definitely, say, hepatic encephalopathy, the head trauma patients, or the patients post-surgical of neurosurgical procedures, in those situations, I think probably the etomidate will be a better options to choose for. But if you think these high-risk patients are not there, we can always go for ketamine because still controversial, but then the availability of etomidate mandates or gives an option not to use it in patients those who appears to be at risk for complications related to the increased intracranial pressures.
Thank you, sir. So, final question, sir. What about the use of ketamine in cardiogenic shock? Because it's, it causes a sympathetic surge and it's a myocardial depressant. So, is it okay or should we just stick to anticoagulate?
In that situation, it's very, if you see ketamine, when the sympathetic consumption has already happened, the patient is totally depleted of all the catecholamines, then it will have the myocardial depression action. So that's why when say the patient is sepsis for long, then and the patient has already compensated followed by decompensation, then we expect that the patient's sympathetic stimulus drive will not be happening with ketamine. And what will we have is with the depression action in those patients. So we have to be a little cautious looking for the journey of these patients, that how they are behaving. And that's why we should not be using those patients who has total depletion of the catecholamines because of the ongoing disease process. Ketamine needs to be avoided in these copro patients again, and the etomidate would be a better option if we have such patients with us.
Thank you, sir. I think there are no questions from the audience. It was a wonderful lecture, very exhaustive, and a lot of pictures and, very nice, complicated airway pictures and ultrasound pictures, which would be very useful to the audience. And a lot of the audience is young and a lot of people from different countries. So thank you very much, sir. And
Thank you, sir.
till the next webinar, thank you very much. And I thank the audience for their patient hearing. And the recording will be available. You can all review it. And for those who were not able to attend it, you can view it on our YouTube channel. Probably in a couple of days, it will be there. Thank you very much, sir. Thank you very much.
Thank you.
Thank the audience.
Sir.